All right, let's talk about EKGs. I want to go through this as a version to help with ISAs and with board exam type questions. So EKGs can quickly become overwhelming, complex. Let's not go there. Let's keep this as simple as possible as we go through it, okay? So 2 rules out on practice, on rotations and in practice. Never rely on the machine to read your EKG. That's the reason why we teach it, because the machines are set to overread these things, and they'll have stuff at the top of the EKG that may be showing normal, or excuse me, abnormal, and really the EKG is actually normal. So always know how to read EKGs yourself, and then you can use the machine to kind of confirm whether or not you think you're on the right track. Also, if you order an EKG, it's your responsibility. Even if you don't order it, someone else ends up ordering it on your patient, someone else who's consulted on them or whatever. Always make sure you review that EKG and make sure there's nothing abnormal that you need to take action on, because again, it will come back to get you later if there's something abnormal and it results in a poor outcome. That being said, let's move along and let's dive into this. All right. Next, this is just an overlay of the normal EKG placements. So when you have this, you have lateral in 1 as well as V5 and V6. You have inferior leads in 2, 3, and AVF. Your septal leads are V1, V2, and then you have anterior leads in V3, V4. And again, that's just showing you where the infarct is. So if I had ST elevations in 2, 3 AVF, that would be an inferior infarct. If I had ST elevations in V1 and V2, that would be a septal infarct. We already talked about this, but really quickly, how to interpret EKG. Look at the rhythm strip at the bottom. A mnemonic, if you need one, remember your P's and Q's and the 3 R's. So what's the P waves look like, and are there any P waves? What's the QRS width? Is it narrow or is it wide, or does it look normal? Is it a regular rhythm or not? Are the P waves actually related to the QRSs, or are they independent of the QRSs, such as a third degree AV block? And what's your rate? We did that already. I'm going to move past this because we covered it. Again, here's the axes. It is important to know these. It's important to know this for your ISA, I'm sure, and it will be on board exams as well as rotations. Leads 1 and AVF are what you look at for your axis. If they're both up, it's normal. If lead 1 is up, it's either going to be normal or it's going to be left axis. So look at your AVF. If it's down, it's left axis deviation. So both up, normal. Lead 1 up, AVF down, left axis deviation. If lead 1 is down, it's got to be a right axis deviation. And if AVF is also down, you have what we call an extreme right axis deviation, just meaning that there's a really significant change in the electrical conduction toward the right. All right, here's some reasons that you might see for these axis deviations. I don't think you need to memorize these necessarily, but be aware that if you see an axis deviation, you should probably think about what might be causing that out on rotations and out in practice, okay? All right, so if we look at this, what's the axis? Of course, it says normal at the top, but I said don't read the top of your EKGs. But moving aside, look at 1 in AVF. 1, is it mostly positive? Yeah, most of that is upright. If you look at AVF, is it mostly positive? And what we mean again by positive or negative is it above that PR baseline or is it below it? Okay, so look at 1, look at your PR. Most of that QRS complex is above it. It does have a little bit of an S wave afterwards, but it's only maybe 2, 3 small boxes at the most. Excuse me, versus 8 or 9 boxes, small boxes above it. So it's positive overall. In your AVF, it's all positive. There is no downward slope of the QRS complex. But again, you would see what's the most number. Is it mostly positive or negative? So normal axis, moving along. Axis again, what's 1? 1 is mostly positive. If you look at this, look at what's above the PR interval. You've got the PR interval here at baseline. Above that, you've got probably about 6, maybe 7 small boxes. Downward sloping from that is about 4, so you've got a positive 3 roughly. Now, that means it's either a normal axis or it's a left axis. So now let's look at AVF. AVF, what is it? Mostly negative. There's very little above that baseline. Most of it's negative. So, this is a left axis deviation. All right, next one. 1, is it mostly negative or mostly positive? If you look at the baseline, we look at this, mostly. All right, let's count what's positive. PR interval going upward, you have probably about 6 small boxes. So there's a positive 6, and then what's downward on the S wave? Probably about 11 small boxes. So there's probably, if you add those together, it's a negative 5 roughly. Okay, so it's down in 1. What's that mean? Well, it's got to be a right axis deviation. And that's either going to be a right axis or a severe right axis. Look at AVF, it's upright, so you have a right axis deviation. If it were down in AVF, it would be a severe right axis deviation. All right, moving along. All right, next thing, look for STT changes like I already talked about. Your 1 through AVF are your inferior leads, V1, V2 septal, V2 through V4, roughly, some people argue V3 and V4, is anterior, and then your lateral leads. So think about how it comes across your heart. So if you look at the V1 through V6, those are the precordial leads. They start on the right side of the heart, they go across. Now the heart is turned a little bit, so it's not really truly right on the right part of the heart at the chest wall where these leads start. They start at the septum and go across. So you start with V1 over the septum, V2's over the septum, V3 and 4 are over the septal area, and then it goes lateral from there out to the left side of the heart. So V4 through V6 is lateral, and then 1 is also going to be a lateral lead. We talked about this before, but if you see ST depression or flip T waves, that's ischemia. ST elevation is an infarct. Q waves can be an old MI most of the time as well. Sometimes you will have early ischemia that gives you a Q wave. So remember the QRS complex. If there's a significant Q wave, in other words, a big box or more, you need to really think old MI, or maybe depending on the clinical setting, there's some ischemia going on now. So someone who just came in with chest pain and has a new Q wave. All right, let's look at this really quick. What do we see here? All right, there's not a rhythm strip at the bottom, so let's ignore that. But what do I see in terms of my leads? There's something that kind of glares out at me, and that's that this 2-3 and AVF has something going on in it. So 2, 3, and AVF. And I look at that, what do I see? That ST line, especially when you look at AVF and 3, is really sloping up. It's kind of flat, and it's elevated above that PR interval, so from that baseline. So you've got some ST elevation. It's in 2 as well, 3 and AVF. So you've got ST elevation in the inferior leads, 2, 3, and AVF, meaning you've got to have an inferior infarct. The inferior leads usually correspond to the right coronary artery, FYI, but you've got an inferior infarct. What do you see in some of the other leads really quick? If we go to V2, 3, V4, V5, V6, you've got ST depression. Those would be considered reciprocal leads, not something you need to dive into for the purposes of ISA and board reading, but those are depressed because electrical activity has changed from the elevation in the inferior leads. So you got an elevation, that's the pressing thing, that's the thing you need to worry about. And this would be an infarct because there are ST elevations. All right, so uncover that, inferior MI, and then some anterior ischemia, but those are reciprocal leads. All right, T-wave inversion. If you look at this, most all the T-waves are inverted. Certainly they are in V1, V2, V3, V4, V5, V6, and lead 1, even in lead 2. What does that mean? You've got diffuse ischemia going on. You've got it in the septum, anterior. You've also got it in the lateral leads. and even a little bit in the inferior lead. But the big key thing in this picture is you've got T-wave inversions. T-wave inversion, think ischemia. Here's another example, T-wave inversion. Look at V2, V3, V4, 5, 6, and lead 1. So you've got some ischemia more than likely occurring. Now, 1 minute, let's look at the rhythm strip at the bottom. What does the rhythm strip at the bottom look like? Because we already jumped to the diagnosis, or the real finding. But is that rhythm strip regular or not? Are the Q waves identical in spacing? Yes or no? No. So you go from one Q wave to the next Q wave to the next Q wave, you're going to get different numbers almost every single time. You can never predict exactly where the Q wave is going to hit, right? Okay. So this is an irregular rhythm. What might you think of if you think of an irregular rhythm? AFib. All right. That being said, let's look for P waves. Do you really see P waves in here? Well, maybe at this very first QRS, on the rhythm strip at the bottom, you might have a P wave. Maybe that second one. The third one, no. The fourth one, not really. The fifth one, no. You're not getting real good defined P waves where you go, yes, I know this is a P wave followed by QRS. What doesn't have P waves and is irregular? AFib. So this is atrial fibrillation, but it also has T-wave inversion and leads V2, 3, 4, 5, and 6. So you have some ischemia going on along with atrial fibrillation. If we look at lead 2, 3, and AVF, just look, it's flipped inverted T-waves in 2. AVF and lead 3 are upright. So no ischemia and contiguous leads in the inferior lead. All right, so atrial fibrillation and ischemia. Next, this is something I always throw in. I don't know that you get tested on this, but I think it's important. We harp on ST depression being ischemia and ST elevation being an actual infarct. However, there's one exception, and this is good out on rotations and for practice, is lead V1. If you ever see a significant ST depression there, like this, try to think of V1 as a mirror image. V1 commonly has an inverted T wave, so it normally has a downward T wave. If there's an infarct in lead V1, there's a posterior infarct, it will give you an ST depression because of the electrical activity, just like a T wave inversion. If you normally have one in that, what would happen with an infarct? Well, you're probably going to get ST depression. It's going to follow the T wave down. So, just to note. Atrial enlargement, don't know that you would need this for your ISA or board exams, but note that if you see a P wave that's really tall and peaked, like a TP, such as this, it's atrial enlargement. All right, so just keep that in mind. 3 millimeters or more, so 3 small boxes or more is what we would consider to be significant in an atrial enlargement. And you usually see that in lead V1 as your most likely place to see it easily. So here's an example, right atrial enlargement. You've got a big peaked P wave right before the QRS in lead V1. You see it in other places, but V1 just stands out the most, and that would be atrial enlargement. So and lead V1 primarily corresponds to the right atrium. All right, left ventricular hypertrophy, or LVH. These are really big, deep QRS complexes in your precordial leads, so V1 through V6. Specifically, if you were to take the S wave depth into V1 and the tallest R wave out of V5 or V6 and add them together, and it's more than 35 millimeters, then you've got left ventricular hypertrophy. So in this case, in lead V1, if you were to count that, there's one, let's see, look at big boxes, 1, 2, 3, 4, 5 big boxes for sure. And then, so that's roughly 20 millimeters And then if you look at V6, how much does it go up? It goes up 1, 2, 3, almost 4 big boxes, which is 20. So you're looking at 40 plus millimeters. So this patient has left ventricular hypertrophy. Clinically, why is that important? Probably someone with long-standing hypertension that was not treated, or they have cardiomyopathy, so they have enlargement of the left ventricle because they truly have cardiomyopathy, or it's enlarged because their heart's been having to beat so hard against high blood pressure that it's enlarged over time from that. All right, intervals. I said this is important before. You definitely need to know this. You should always think about the SPR interval. Normally it should be 0.12 to 0.2 seconds, 3 to 5 small squares. QTC should be 0.42 seconds or less, and there is a minimum criteria on it too, but really pay attention to prolonged QTC. So that's roughly 10 small boxes. That would be 0.4 seconds. So if the QTC, again, starting at the beginning of the QRS complex to the end of the T wave, if that is greater than greater than 2 big boxes, that's a prolonged QT interval. And then you got to think about what could be causing that. And again, it goes back to hypokalemia, digoxin toxicity, or hypercalcemia primarily. There are some other medications that can cause it too, like tricyclic antidepressants. Bundle branch blocks, we need to talk about that. Those are the bunny ears, as we call them, the RR prime, we'll cover it in a minute, in 2 or more leads out of V1 through V3 or V4 through V6. And those are going to correspond to the right bundle branch in V1 through V3 or the left bundle branch in V4 through V5. Left anterior fascicular block, the LAFB, I think you can ignore for now. All right, prolonged QT. If we look at this, what do we see? It's already got it drawn on here, so it's kind of nice. Where's your QTC interval? So right there in the middle is your QTC already shown. But look at the line. It's starting from the beginning of the QRS complex to the end of the T wave. How many big boxes is that? Let's see, 1, 2, almost 3 big boxes. Each big box is 0.2 seconds, right? So 3 big boxes, 0.2, 0.6. And they calculated it out to be exactly 0.56. It's greater than 0.42, greater than 2 big boxes. Therefore, it's a prolonged QT. Then you got to think hypokalemia, hypercalcemia, digoxin toxicity, or some other drug causing this, right? All right, here's an EKG. First things first, look at a rhythm strip at the bottom. Does that look regular or not? If I go from one R wave to the next R wave, to the next R wave, to the next R wave, are those pretty equally spaced? Yes, they're pretty equally spaced. I can pretty well predict when the next QRS complex will occur. Are there P waves? Well, kind of hard to tell, but you can kind of make yourself believe, yep, there's probably a P wave there beforehand. You do have a little hump that is more than this static interference or whatever's going on in this lead. You can even look at some of the other leads like V1 and V2 and see, do you see a P wave? When I come up to V1 and V2, yeah, I definitely see a P wave. So there's P waves. So this is sinus. It's regular. All right. The lines can't be seen good on here, so I can't really calculate out the rate, but don't need that right now. Let's look at V1 through V3. What do you see? Bunny ears, RR prime. In V1, V2. They look kind of like bunny ears, right? One shorter than the other one, but they're bunny ears. V1, V2 have bunny ears. So bunny ears in V1 through V3 is a right bundle branch block. All right. If it were in V4 through V6, it'd be a left bundle branch block. So let's move along. Here's another example, right bundle branch block. When you look in V2 and V3, you can see bunny ears, or the RR prime, if you want to be technical about it. So I've got a right bundle branch block. Left bundle branch block. Left bundle branch block throws a whole lot of the EKG off. A lot of the electrical activity gets messed up, so when you look at it, you go, oh my gosh, what is this? It gives you a wide QRS complex for one thing. So does a right bundle branch block, but not nearly to the degree of a left bundle branch block. Left bundle branch block tends to give you more negative electrical activity too. But Let's look at V4 through V6. What do you see? Especially at the bottom of V4, when that QRS complex comes all the way down to the bottom, it doesn't just have one little sharp turn, it's two. That's bunny ears. It's kind of like a bunny hanging upside down, but it's bunny ears. V5 has the same thing. V6, it's up right there, but you have bunny ears. So we have bunny ears V4 through V6. That's a left bundle branch block. All right, what about this EKG? Let's look at a rhythm strip at the bottom. Here you actually have three rhythm strips. You have V1, 2, and V5 to choose from. I like lead 2 as my choice of rhythm strip because that's kind of the most normal, so to speak, strip to look at. So if you look at that, is this regular? It's regular, right? Because you have a Q wave to, sorry, an R wave to an R wave, to the next R wave, to the next R wave, to the next R wave. They all look equal. I can pretty well predict exactly when that R wave will occur. So it's regular. So pretty much it can't be atrial fibrillation. I can just go ahead and get that off the table. Probably not atrial flutter either, especially since I don't have a sawtooth pattern that we'll talk about in a minute. Do I have P waves before each QRS? Yeah, when you look, you really do have a P wave before every QRS, right? So it's sinus rhythm, it's regular, okay? What's the rate? Well, the rate, we count big boxes, which is going to be difficult to do on this. If I look, big box 1, 2, 3, roughly. So 300 divided by 3 is 100. All right, the machine at the top, if you want to look at it, it reads at 116, depending on exactly where it's drawing a line on these. But around 100, which is tachycardia, but it's sinus tachycardia, right? Because we know it's got a P wave. Therefore, it's got to be a sinus beat, and it's tachy, so it's sinus tachycardia. All right, what else do I want to know about this? All right, let's look at axis next. Where do we go for axis? 1, AVF. Is lead 1 upright mostly? Yep. So it's either going to be a normal axis or a left axis deviation. Go to the AVF, is it mostly positive? Yep. So it is normal axis. Now, what else do we want to know? I can look for ischemia and infarcts. Let's look at inferior leads, 2, 3 AVF. 2, do you have a T-wave inversion? No. In 3, no. Excuse me, in AVF, do we? No. Do you have ST elevation? I would argue you do not have ST elevation in 2, 3, and AVF. All right. What about your precordial leads? V1, 2, 3, 4, 5, and 6. Do you have ST elevation? Maybe. Here's where it gets tricky. Why do these waves all look kind of odd? Really big, QRS complexes, kind of wide, and kind of uniform between V1, V2, V3. Well, if you look over at 4, 5, and 6, you actually have bunny ears, and you can especially see that in a downward slope in V4. You've got an upside down bunny hanging there with his bunny ears down. And then in V5, you've got upright bunny ears, or R prime. That's why you've got a widened QRS, because you've got a bundle branch block. Electrical activity is taking time to go through and widens that QRS out. So this has bunny ears in V4, 5, and 6. What is that? Left bundle branch block, right? The rest of this EKG, in terms of trying to determine ST elevations, ST depressions, kind of is out the window because that left bundle branch block throws off the EKG. That's something to know when you get out on rotations out in residency with. And also anyone with a new, let's move along. Left anterior fascicular block, again, I don't think you're going to need to know that. It's in lead 2, and if lead 2 is mostly negative, then that's a left anterior fascicular block. I don't think you really need to know that. All right, look at normal EKG. just another example, normal EKG. If I look at the axis, lead 1 and AVF, are they mostly positive in each one or negative? 1 is mostly positive, AVF is mostly positive, normal axis. 2, 3 AVF, T waves upright or flipped? They're upright, so no ischemia there. What about infarcts? Are there any ST elevations? And for that matter, are there any ST depressions, which is also ischemia? Nope. ST line is right where it should be, along with the PR interval, basically. So it's right at baseline. Let's look at B1, 2, 3, 4, 5, and 6. Follow it along as we go. Any T-wave inversions? Nope. Are there any ST elevations or depressions? Nope. Some of these T-waves are a little bit bigger than what you might see on other EKGs, but it's just in some of the leads. It's not on every lead. So for whatever reason, it's just picking up that T-wave better in V2, V3, V4, V5 especially. But the ST segment itself is right at baseline. All right. So that's a pretty normal EKG. All right, rhythm strip. If you look at this, is it regular? What do I mean? Are the QRS complexes equally spaced from R wave to R wave to R wave to R wave to R wave? They're equal. So it's regular. Can't be AFib. Probably not A flutter. Does it have a P wave before every QRS? Yes, P wave, P wave, P wave, P wave, P wave. So I know that it's got to be sinus. So what's the rate? Well, how many big boxes do I have from this first R wave to the second? 1, 2, 3, 4. Basically 4 big boxes or big lines in between. 300 divided by 4, 75. So I have normal sinus rhythm rate of 75. Pretty good amount of information. All right, what do we think about this EKG? What do we see? Well, part of this is it's only part of an EKG. What leads do we have? B1, B2, B3, 4, 5, and 6. What stands out? Looking at B1, B2, and B3, what do you see? Bunny ears, right? You got that RR prime, or bunny ears, in B1 through B3. Bunny ears must mean a bundle branch block. If it's in B1 through B3, is it right or left? It's a right bundle branch block. Okay, let's look at this EKG. What do we see? Well, one thing that really sticks out to me right away is I can't help but notice that there's these really big T waves in V2, V3, V4, V5. So that is what stands out to me really quick. Now I can look at the rest of the EKG and go through it, and I welcome you to do so to see if there's anything else showing up. But what really stands out are these big peak T waves. Now notice that these are a little dramatic. You won't necessarily have T waves this huge as an example always, but know that a T wave is not very big normally. It's a little bit bigger than the P wave, but not by much. So if it's a lot bigger than the P wave, and especially if it has a tent shape to it or TP shape to it, you got to think that's a really big peaked T wave. And what do we think about peaked T waves? Hyperkalemia, right? So there you go. And this is a case in renal failure. Your kidneys aren't clearing like they should, therefore they don't excrete potassium, therefore you build up potassium, become hyperkalemic, get really big peak T waves. All right, what about this one? Well, what I notice is right in the middle there's something different than at the beginning or at the end. These are really wide waves, so they're probably ventricular in nature because the ventricle always has wide waves if it beats on its own or has a sudden beat, whereas anything above the AV node is going to be a small QRS complex. So I have small QRS complexes in 3 beats, and I have these big wide waves that are pretty equal in size, pretty equal in shape, and then it goes back to regular again. So what could this be? Also think about the rate from one Q wave to the, or excuse me, one R wave to the next, and these R waves are a little off, but what's the rate? It's basically two big boxes. So 300 divided by 2 is what? 150. So it's tachycardic. And by the way, these are big wide QRSs, must be ventricular, it's ventricular tachycardia. VTAC. All right, what about this? You might want to shock it. So this is VFib. It's wide waves when you look at it, and it's very much not discernible. There's no wave I can really look at and go, okay, that looks just like the other one. It's really odd in terms of there's so much shape form going on in it. They're small and all over the place. So VFib. All right, here's something that's kind of neat. May or may not be pertinent, I don't know, to ISAs. It is neat to know for rotations and practice, maybe even board exams. I could see them certainly throwing this on level 1 or level 2. So it's something called electrical alterams. If you look at the rhythm strip at the bottom, it's lead 2. What do you see with the QRSs? One, they're pretty regularly spaced apart. But what's going on? You have a big QRS, a small one, a big one, a small one, a big one, a small one, and so on. It's alternating between. What happens is that's usually pericardial effusion, sometimes pericarditis. You get fluid buildup in the pericardium, and the heart becomes kind of squished from the fluid, but also because the heart is in that fluid kind of floating around, so to speak. When it beats, one time it might slosh toward the chest wall and give you a big electrical activity because it's getting closer to the EKG leads. And in the next beat, it's kind of pushed away. Next beat is pushed back closer as that heart is kind of sloshing back and forth inside the pericardium. And so you get a strong electrical activity, a weak one, a strong one, a weak one, a strong one, a weak one. Clinically, if you were to take the pulse of this patient, you would have a strong pulse, weak pulse, weak pulse, and so on, because it literally causes the pulse also to do the same thing. And we call that pulsus paradoxus. It's a paradoxical kind of rhythm, pulse. You don't expect it, but all right. AFib. I already told you the answer, but look at the rhythm strip at the bottom. That one is V1. But look at the QRS. Is that regular or not regular? Not regular. If I look at some of these Q waves or QRS complexes, to R wave to R wave, to the next R wave to next R wave, they're differently spaced, and I can't really predict where the next one's going to fall. Okay, so it's not regular. Got to think maybe AFib. Are there any P waves before these QRSs? I'll even come up to lead 2, 3, AVF, see if I can see any P waves there, because they're usually easier to see than in lead V1. Do I have P waves? Nope. I have some static kind of stuff, you know, kind of wavy, really light, but no real P waves. So no P waves, irregular. What is it? It's AFib. Okay. You could look at your leads and make sure you don't have anything else going on. Let's look at the axis real quick. Lead 1, positive or negative? Positive. It's mostly all upright. So it's either got to be a normal axis or a left axis. What about AVF? Mostly negative. It's upright in 1, down in AVF. We have a left axis deviation. All right. Now you can look at 2, 3 in AVF. Two, 3 in AVF. Do you have any inverted T waves? No. Do you have ST elevation or ST depression? No. No ischemia, no invert in the inferior leads, which is 2, 3 in AVF. All right, precordial leads, V1, 2, 3, 4, 5, and 6. Do you have any flipped T waves? No. Do you have any ST elevation? No. Do you have ST depression? If you look really close, V4, 5, and 6, you do have a little bit of ST depression. It's not very significant. It may be like one little box, if that. So I wouldn't call it significant. But just a note, yeah, it's a little off base, but all right. So atrial fibrillation, left axis deviation, no ischemia, no infarct, no flip T waves or inverted T waves. Sawtooth pattern, AFib. All right, you see these nice saw teeth on this, and then it's pretty regular or sometimes irregular, it just depends. If it's usually a fast beat, a flutter likes to run at 150 beats a minute, sometimes down to 100. So this one, it's about 100. It's 3 boxes, 3 big boxes divided into 300 is 100, right? All right, next one. What do you see on this? One thing I see that I really note is there's this weird shaped beat. That is, I'm seeing mostly in AVR, AVL, and AVF, right? So right there, what is that? It's got a wide QRS, so it's probably ventricular in nature. The rest of the rhythm, if you look at the rhythm strip at the bottom, it's pretty regular. So all of a sudden we have this weird beat out of nowhere, right? And it looks ventricular because it's wide QRS. And it's pretty huge. This is a premature ventricular contraction, PVC. Almost every single PVC looks almost just like this. If you Google PVC and do an image search, first you'll come up with PVC pipe, which I figured out the hard way. So search PVC EKG, just FYI. So you'll see that they're almost all identical to this. Big old wide QRS. The T wave is really drawn out from it, and it's just an extra beat in the middle of it. Lots of caffeine, stress, anxiety, stuff like that contribute to it. Oops, I might have just rewound this a little bit. So just in case I rewound it a little bit on this side, what do I see? If I look at this, I notice that in 1 in AVF, if I try to look at the axis, I notice that 1 has ST elevation in it, and in AVF has ST depression a little bit. The inferior leads, 2, 3 in AVF. Well, 2 looks okay, 3 in AVF have ST depression. B2, 3, 4, 5, and 6, big ST elevations. And so 4, 5, and 6 in lead 1 are lateral wall. They have a huge lateral wall infarct. All right, next one. Again, I'll go over this again just in case when I backed up the recording cut it off. What do I see? Let's look at the rhythm strip first. Lead 2. Oh, well, I noticed that there's some ST elevation, but let's look past that for a second. Is this regular? Yep. The R waves are pretty equally spaced. Good. Or is there a P wave before each one? Yep. So it's sinus rhythm, and it's regular. So, good. What's the rate? There's approximately 4 big boxes in between, so 300 divided by 4, 75. Let's go to our axis, lead 1 in AVF. I notice that AVF has an ST elevation in it, but it's mostly positive, and lead 1 is mostly positive, so it's a normal axis. 2, 3 in AVF is my inferior leads, most common site for an MI. What's going on? ST elevation in all 3 leads. I have some ST depression in B2, 3, 4, 5, and 6, and that's reciprocal leads. Electrical activity changed because of the infarct that's causing the ST elevations in 2, 3, and AVF, and we have some changes of ST depression elsewhere. But you would call that an acute inferior wall infarct. All right, what do you see here? What's the rate? Or actually, what's the rhythm? Is it normal? Is it regular? Or what? So first things first, regular or irregular? Regular, right? You can pretty well predict where the next R wave is going to occur. R waves are all equally spaced apart. Okay, what's the rate? 2 big boxes between R waves, 300 divided by 2, 150. All right, you got a narrow QRS complex. You've got a rate of 150, and it's regular. Hard to tell if there's P waves because you've got T wave really close to the next QRS. But what might give you a really regular pattern beating 150 beats a minute? SVT, supraventricular tachycardia. How do you treat that? Adenosine. Stops the heart, and then it restarts, and usually it's always back in rhythm. All right, this next one, what do we have? Well, first, we look at it on the rhythm strip at the bottom. Is that regular or irregular? Looks kind of irregular, doesn't it? From one R wave to the next. Some of them are really close together. Some of them are spaced out a little bit more. So we've got irregular rhythm. Is there a P wave before every QRS? Some of them it looks kind of like it. Other ones, no. Other ones, maybe it's the T wave. So when you look through that, yeah, I don't know. So, irregular, probably not really true P waves. What do you think? AFib. All right. Rest of that, if you want to look at it real quick, one is almost isoelectric, but it's a little bit more positive than negative. AVF is all positive, so you have a normal axis. Lead 2, 3, AVF. T waves, upright or inverted? Upright. ST elevation or depression? Nope. B1, 2, 3, 4, 5, and 6. Upright T waves? Yes. Questionable in V1, and that's okay because it normally has an inverted T wave in a lot of people, and that's just normal. Do I have ST elevation or depression in any of those leads? Nope. Good. So, no ischemia, no infarct, atrial fibrillation. Rate's hard to determine because, again, it's atrial fib. This is where I let the machine tell me what the rate is. But, from one lead to another one, from one beat to another, it might be 150, another beat it might be 75. So, all right, good. All right. So again, AFib, you have kind of some fibrillation. You don't really have discerned P waves, and you certainly have an irregular beat, just like this. Atrial flutter, you get the sawtooth pattern. All right, what do you see here? Is this regular? No. But what do you see that stands out? You have a lot of different activity, right? One key thing is if you look at the very beginning, the middle, and the end, you have big waves. And then in between those, you have little waves. Those big waves are wide complex, so it's ventricular in nature. You might be saying maybe be TAC, maybe be fib. There's something kind of a cousin to those, which throws these middle in-between ones as smaller. Some people might even say it's twisting to where if it were 3D, you've got the beats going up and down and then it twists, so they're going into and out of the monitor, so you're looking at it that direction, and then it continues to flip, and it's where you're looking at it upright again. So twisting of the points or torsades de points, which does quickly develop into VFib. All right, here's an example of hyperkalemia. You've got big T waves, especially V3, 4, 5, and 6. All right, what do you see on this one? V1, regular, irregular. Looks pretty regular, right? R wave to R wave, pretty well spaced out. Do you have a P wave before each one? I think so. If you go up to lead 2, yeah, there's definitely a P wave there. All right, so it's regular, it's sinus. What's the rate? Well, when you get to counting big boxes, you got 1, 2, 3, 4, 5, 6, 7 divided by 300. That's less than 60. So, but it's sinus. It's regular. It's sinus bradycardia. All right, next one. What do you see on the rhythm strip? Regular or irregular? Pretty regular. Pretty well spaced out, appropriately so. Hard to tell if there's P waves. What's the rate? How many big boxes in between the R waves? 2. 2 divided into 300 to 150. Rate is 150. A really fast beat right at 150. Really regular. Maybe, maybe not P waves. What do you think? Could be SVT. It's hard to tell sometimes, is it sinus tach or SVT? On this, we're calling it sinus tach, a rate of 150. I would argue, though, that this is probably more SVT. All right, second degree blocks, MOVIT. So first degree block is a PR interval that is greater than 0.2, which is 5 small boxes, right? All right. Second degree blocks come in 2 severities. There's a relatively mild one, which is Mobitz 1 or Winky Bach, and then there's a more serious one, which is a Mobitz 2. Mobitz 1, which is Winky Bach, is shown here. If you look at the PR interval, it continues to increase until it drops the QRS beat. So look at the bottom, we've got lead 2 here. You've got a PR interval that's fairly normal, then it enlarges, then it gets bigger, and then eventually it drops the QRS. And then it starts over. And in fact, if you were to take those first 4 beats and the next 4 beats, they kind of look pretty close to the same, especially in terms of the PR interval. So it's, as some people have told, it's kind of like it's winking at you until it disappears, or like a light is kind of blinking, and it blinks and blinks and blinks and then burns out. And that's a Winky Bach. Not as severe as the Mobitz 2. The Mobitz 2, the PR intervals are actually normally spaced, looks okay, and all of a sudden you just drop a beat out of nowhere. So it doesn't even warn you, it just drops it. Okay? So here's a Winky Bach. You can look and you see from PR it's kind of normal, then it's bigger, then drops. What about this one? Look at the rhythm strip at the bottom, lead 2. You got PR and then your QRS, your T. Go to the next one, the next one, the next one. Do all those PRs look pretty close in distance? Yeah, pretty close. But then all of a sudden you drop a beat out of nowhere. Boom. That is a Mobitz type 2. All right. That one's more severe and has a chance of turning into a 3rd degree block. That's the reason why cardiologists will take this one a little bit more seriously than a Winky Bach. 3rd degree block, you have complete disassociation. The atria is firing, the ventricle's firing, neither one are communicating with each other. So you have P waves all throughout, and they're pretty equally spaced, and you have QRSs all pretty well equally spaced, but they do not correspond with each other. So, all right, what do you see here? The arrow's pointing to, what is that? Wide QRS, has this drawn out T wave, PVC, premature ventricular contraction. The rest of the beats look pretty regular. All of a sudden, boom, you get an extra ventricular beat. All right, here's some reasons for shortened QT, prolonged QT, etc. You can look at those. We talked about some of it. All right, quiz time. What do you see in this EKG? All right, so I don't have a rhythm strip, can't look at that. But let's look at axis, 1 and AVF. 1 is up, AVF is got something going on with it, but it's mostly positive. So normal axis, 2, 3 and AVF, inferior leads. Do I have T-wave inversion? No. Do I have ST elevation or depression? Yes. ST elevation in 2, 3 AVF, and then I have some depression that corresponds to that in 2, 3, 4, 5, and 6. So I have what? Not normal. I don't see a right bundle branch block. There's no bunny ears in B1, B2, B3. It's not atrial fib, because if I look at this, I do have some P waves on here before QRS, especially look at lead 1, you've got P wave, QRS. Acute inferior MI, right? 2, 3 and AVF, inferior leads. So, all right, next one. What's the rate? How do we determine that? Quick and easy way. How many big boxes divided into 300? So from one ROA to the next, 1, 2, 3, 4 roughly. Divided into 300, 75. All right, what's the axis on this? Where do we go for axis? 1 and AVF. 1 is up, so it's either going to be normal axis or left axis, right? AVF is down. It's what? Left axis deviation. What's the rhythm here? A whole lot of badness, but there's no true defined PQRST stuff. No QRS complexes. It's not discernible. You can't tell one beat to the next what's going to happen. It's all different, and it's kind of just fibrillating, right? So, BFib. How do you first treat the previous patient? I just told you. So you shock them, right? Immediate defibrillation. Shock them back into. All right, on this one, what does the patient have? Look at the rhythm strip at the bottom, lead 2. What do you see? Is it regular or irregular? Distance-wise from R to R, it's pretty regular, right? You can pretty well predict it. They're pretty well equally spaced apart. All right, but what do you see also? Big QRS, small QRS, big QRS, smaller QRS, big QRS, smaller QRS, etc. So what is it? Well, it's called what? Electrical alterans, which corresponds probably to a pericardial effusion. What do we have here? Rhythm strip at the bottom, 2. Regular or irregular? Regular. They're pretty well equally spaced apart, right? From one R wave to the next. So, can't be AFib, probably not A flutter. You don't see a sawtooth pattern either, do you? So, not A flutter. Acute inferior MI is number 4. Look at 2, 3, and AVF. Do you see any ST elevations? Nope. T waves upright? Yep. ST depression even? Nope. So it ain't acute inferior MI. You do see some almost fibrillation stuff, especially in lead 3, 1, AVL, AVR. That's interference. Probably somebody had their cell phone on and it interfered with the EKG machine. So you'll see that out in practice too. It's annoying. All right, what do we got here? Look at the rhythm strip at the bottom, lead 2. Regular or irregular? Regular. Very equally spaced. What's the rate? 150. What is really regular at a rate of 150? Yeah, SVT. It's not AFib because it's regular. And definitely not VFib. It's not wide and it doesn't look like, all scattered all over the place where you can't discern it. And it's not A flutter because it doesn't have sawtooth pattern. And again, it's quite regular. How would you treat this patient with SVT? Adenosine, which will stop their heart momentarily. Everyone in the room stops breathing for a moment, and then it restarts. All right, what do we got here? Look at the bottom, the rhythm strip, lead 2. Regular or irregular? Regular. R's are all equally spaced. Do you have a P wave before every QRS? Yep, we do. All right. Normal axis, left axis, or right axis? One's up, AVF's up, normal axis. All right, inferior leads, T waves upright? Yes, they are. ST elevation and depression? Nope. How about B1, 2, 3, 4, 5, and 6? T waves upright? Yes. ST elevation and depression? No. So, is there anything really? Do you have a right bundle branch block? You don't have bunny ears in B1, 2, and B3, right? So, right bundle branch is out, AFib is out because it's regular and it's got P waves. Inferior ischemia, we said no because we already looked at that. No ST elevation and depression or T wave inversion in 2, 3, and AVF. So, this is normal. What about this one? Bottom strip. Regular or irregular? Looks pretty regularly spaced. I question whether or not there are P waves, but look up at lead 1 and, well, lead 1 especially. You can see a P wave before the QRS. So it's regular, it's got P waves. What else do you see on this? Normal axis, because 1 and AVF are up. 2, 3 and AVF. T waves are upright, no ST elevation depression. So no ischemia or infarct in the inferior leads. B1 through 3, I've got something going on. Wide QRS, I've got bunny ears. Bunny ears in B1, 2, 3, what is it? Right bundle branch block. All right, some extra EKGs just for fun. Rhythm strip bottom, lead 2, regular or irregular? It is regular. Do you have P waves before each one? Yes. Rate is what? Roughly 3 big boxes in between the R waves. 3 divided into 300 is 100. It is sinus, it is regular, and it's tachy, sinus tachycardia. All right. What do we have here? It's hard to see because some of these lines aren't showing up. Obviously very good, but at the bottom, is it regular or irregular? Mostly regular. There's like one that may be off a little bit, but it's mostly regular. It's questionable whether or not there's a P wave. So that's hard to determine. It is, if you had lines on here better, you would see that it's slow though, so probably sinus bradycardia. Next one, is it regular or irregular at bottom? Irregular. P waves before each QRS? No. You've got AFib. Alright. This I just worked through a case, 49-year-old, history of coronary disease, MI, complaining of chest pain for 30 minutes. If you work through this, there's nothing really that stands out that much. What I want you to pay attention to is your T waves, or the T waves upright in 1, 2, 3 in AVF. No, they're kind of flat. Not upright, not inverted. B1, 2, 3, 4, 5, and 6. T waves, upright. Now, same patient 30 minutes later, repeated because he continued to complain of chest pain that was getting worse and worse. What do you have? Look at 2, 3 in AVF. They were flat in the previous EKG. What are they now? Inverted. B1 through B6, they're upright, except B5 and 6 has got a little bit of T-wave inversion as well, actually. So you have some T-wave inversion. T-wave inversion corresponds to what? Ischemia. So he's got some developing ischemia. Here's some resources if you'd like. So to note, if you were to look at the EKG as in terms of boxes, one small box is equal to how many millimeters? It's equal to 1 millimeter, right? It's, okay. One big box has five small boxes in it, so that's 5 millimeters. All right.